Good evening and welcome to Doctors on Call. Tonight we're going to be talking about the diagnosis and treatment of arthritis, bursitis, tendonitis, and rheumatoid arthritis. I'm Dr. Alan Johns from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth, and I'll be your host this evening. We'll be happy to answer your questions about arthritis. Just give us a call locally at 218-788-2844 or toll free at 1-877-307-8762. I'm pleased to welcome our panelists this evening. Dr. Gail Baldwin, a family medicine physician with the Twin Ports VA Clinic in Superior. Dr. Anna Fernandez, a rheumatologist with Essentia Health-Duluth Clinic. And Dr. Waseem Khan, a rheumatologist with St. Luke's Rheumatology Associates in Duluth. And we have our medical students answering phones tonight. Kate Aries from Hutchinson, Minnesota, Ann Doring from Dayton, Minnesota, and Haley Roberts of Staples, Minnesota. And now on to tonight's program on arthritis. Well, Dr. Baldwin, maybe I can just start out and ask you on our promo there, we talked about arthritis, bursitis. What's the difference between arthritis and bursitis?
Well, arthritis involves the joint, and bursitis involves the bursa around the joint that assists in the movement of the joint. But they're both inflammatory.
Thank you. And Dr. Fernandez, how can you know if it's bursitis or tendonitis or arthritis?
Well, I think that's important because a patient may experience pain in a joint, and we forget that the joint is made up of the cartilage, the ligament, the tendons, the muscles, and the bursas. A physical exam will help us figure out the difference between one and the other. We really want to identify arthritis because of the arthritis that cause inflammation, like rheumatoid arthritis, are really important to recognize early on. So a good physical exam will help us figure out whether it's a tendon involvement, whether it's a bursa, or whether it's part of the joint.
Okay. Thank you. So, I mean, physical exam is one thing, but we hear about football players getting MRIs of everything at the drop of a hat. So, I mean, when do you do an MRI? Does that help out with any of these diagnostic problems?
Typically not, unless there is some injury. Usually to tell between bursitis and arthritis, a good way to tell is by moving the joint. I mean, if the pain is arising from the joint due to arthritis, movement can reproduce the pain. If it is extra-articular, let's say a bursa or a tendon, it's reproduced more with local palpation. Another way to tell the difference between bursitis and arthritis is arthritic pain, especially in the knee. If someone has knee osteoarthritis, is noticed more when you walk or stand. Bursitis pain is independent of that. You can have bursitis in the knee and pain at night, for instance. So a couple of ways to tell the difference between the two.
Well, thank you. When it comes to treatment of those various things, we'll get into treatment of arthritis later, but what about bursitis and tendonitis, Dr. Baldwin? How do you treat those?
Well, usually pretty conservatively. I'll treat with a non-steroidal anti-inflammatory drug sometimes, but mostly try to treat with heat or cold, or sometimes physical therapy to help. Sometimes things like ultrasound will give some relief, but the idea is to reduce the inflammation in those areas, and those are three things that I commonly try.
Another good trick that patients may like are the topical rubs. There's some arthritic rubs that may have salicylate that may work very well for those superficial areas of tendons and bursas. So that may be a good thing to try.
Can you get those over the counter? Or
yes,
those prescription?
there's several that are over the counter,
Uh-huh.
and there's one or a couple that may be prescription, but they're topical. So people who may have a sensitive stomach or history of ulcers that cannot take the anti-inflammatory medications may like to try some of these arthritic rubs.
Okay, Dr. Khan, should we rest these joints if they're inflamed?
Yeah, it depends on the mechanism of injury. So if it's an acute injury, rest, ice, and maybe some physical therapy usually work. So whether to rest a joint or not depends on whether it's an acute injury or if it's a more systemic chronic problem where the treatments are obviously different.
Sure. Okay, thank you. Yeah. Dr. Baldwin, we have a caller from Evelyn wanting to know What's the difference between rheumatoid arthritis and osteoarthritis? That's a good question.
Well, both have inflammatory phases, but the rheumatoid arthritis is one that seems to be much more damaging to the joint. Osteoarthritis, you'll have phases where the joint may be inflamed, but most of the time it's a rather chronic joint problem that the inflammation doesn't result in quite as much damage to the joint. I think that I know less about the specific changes in the joint that happen than both of you.
And that's important. The osteoarthritis, cartilage in between the joint tends to thin out because of use, because of an injury. I tell patients, think of it as the old couch with the cushions that are kind of losing a little bit of its springiness. And it's important to differentiate that from the rheumatoid arthritis, because the rheumatoid arthritis is the inflammation of the lining of the joint, and it can be very destructive very quickly. So there is a lot of interest in making sure that we recognize rheumatoid arthritis and not let it go, because then the damage is irreversible. We cannot take it back.
Dr. Khan, a caller from Superior would like to know, is rheumatoid arthritis hereditary?
Yes and no. There is a hereditary component to rheumatoid arthritis, but it's not a cinch that if the parent has it, the child will automatically get it. They've done studies among identical twins, actually. If one twin gets rheumatoid arthritis, the chances that the other identical twin will get rheumatoid is about 30 to 40%. So despite having almost identical genes, there are environmental factors that come into play as well. So if it were all genes, you would expect both twins to get it.
Well, that's interesting. Dr. Baldwin, a caller, wants to know about glucosamine chondroitin supplement.
Well, the theory behind that is that it helps you to restore your cartilage and therefore is probably very useful in osteoarthritis. The studies are really mixed. There are some studies that will say there is an improvement in symptoms. That I haven't seen any studies that say it actually changes the cartilage in the joint at all. But what I tell folks is there's very little downside if they want to try it, and it does give them relief. There's little downside to it other than in the pocketbook.
So it's safe to use then?
Yeah, I think it's usually safe to use, and the effectiveness is not proven, let's just say.
Great. Dr. Fernandez, a caller from Evelyn, wants to know about what are the treatments for osteoarthritis?
So osteoarthritis, remember, is where the cartilage has thinned out. We used to call it the wear and tear arthritis. We call it degenerative arthritis. When you go to the doctor and they do an x-ray, sometimes they say, oh, you just have arthritis. This is the one that we're referring to. So treatment can start with, if the pain is mild, something like acetaminophen products. If the pain is more than that or acetaminophen does not work, then we're talking the anti-inflammatory medications, things like ibuprofen and Aleve and the like. The arthritic rubs that we mentioned can also be very helpful to patients. If the patient is experiencing pain in the knee and they happen to have a few extra pounds, weight loss can be very helpful in the management of the arthritis of the knee. An exercise routine, staying active, tends to be very helpful. We have some people who try the glucosamine, like you mentioned. We do cortisone injections that can help. There's a series of hyaluronic acid derivative injections. We tease patients, we say the chicken shots may help for osteoarthritis.
Yeah, that's a good question. Actually, one of the callers wanted to know about that also. Does that work?
There are some patients that feel that it may alleviate their pain. It doesn't really rebuild the cartilage. And so it is tried in an attempt at reducing the pain, or someone who maybe cannot proceed to surgery, to replacement surgery, which is really, if all these conservative measures fail, then that's where the patient will get some relief.
Thank you. Dr. Khan, actually we were talking about this just before we came on the air. A caller from Southridge wants to know about immune modifiers as far as rheumatoid arthritis, and how do you determine when to start one and how they may help?
That's a very good question, because if it's true rheumatoid arthritis, immune modifiers, or we call them disease-modifying drugs, have literally changed the course of the disease. Because unlike osteoarthritis, even if you osteoarthritis, even if you don't use any modifying drugs, and there are none, you just treat them symptomatically. But in rheumatoid arthritis, unless you go to the source of the problem, which is an overactive immune system, and modulate that, it can cause a lot of destruction, which can lead to deformities, disability eventually. So the choice depends on the stage, and to answer that question, if it is true rheumatoid arthritis, most people should go on an immune modifier.
So usually the treatment is you use these at the start of the illness,
exactly,
before the destruction
exactly.
is taking
And
place.
there is a lot of recent data that the sooner you start these treatment, the better the eventual outcome.
Very good, thank you. Dr. Baldwin, a caller from Duluth, wants to know about spinal stenosis, and what can you do about spinal stenosis?
Well, spinal stenosis is a tough one. If spinal stenosis occurs due to some narrowing of the canal where the spine, or where the spinal cord runs through, sometimes surgical intervention can be helpful, but so often the spinal stenosis isn't going to be helped that much by surgical procedures. So symptomatic care there, exercise programs to restore more normal core function of the muscles to hold yourself in a good posture, doing things that keep your body fit, get rid of extra weight so that you don't develop a bow back posture that will exacerbate things. Those are the main treatments for the spinal stenosis.
And eventually surgery is the
You have to.
cure.
Yeah, well, for some, I find that a lot of the patients
Yes.
I take care of are at a stage in their spinal stenosis or their health that
Yes.
it's just not an option.
Yeah.
And it probably won't cure them, but some very.
Dr. Fernandez, a caller from Proctor, my old hometown. Polymyalgia rheumatica, is it chronic? Can it be treated or cured?
So polymyalgia rheumatica is typically a condition seen in patients that are 50 years of age and older. They complain of a lot of muscle pain in the shoulder and hip area, making it very difficult to raise their arms above their heads or get up from a chair. They have elevated markers in the blood that show inflammation, and it's usually treated with prednisone. A lot of patients may be successful in going through a course of prednisone. A slow taper is not like you take prednisone for a few weeks and you're done, so they need prednisone for a long period of time. There is a subset of patients whose polymyalgia rheumatica may become more chronic, and they may need prednisone longer periods of time. And we also have a subset of patients that may need very low doses of prednisone, particularly if they're elderly. They may need to remain on maybe 1 to 3 milligrams of prednisone a day long term. So for some patients, it may be more of a chronic situation.
Dr. Khan, a caller from Duluth would like to know, does diet affect arthritis? Or, I mean, dietary changes, does that have any role, sugar, any of those things?
Sure, that's a broad-based question. Typically in osteoarthritis, if someone is obese or overweight, losing some pounds will certainly help, because basically you're talking about overloading the joints. So clearly, yes, and good diet, who can argue against that?
True enough.
There are some patients with, for example, rheumatoid arthritis, who will come and make a comment or an observation that they did eat a lot of sugar and they're worse, or they drank diet pop and they're worse. So it's not universal, but if you do feel that you eat something or your diet is not as good and you change it and you feel better, listen to your body.
Great. Thank you. Dr. Baldwin, here's another type of arthritis, gout. Question from Duluth, and yes, can gout cause arthritis? And how do you tell if you have a gout attack or it's just some other osteoarthritis?
Well, gouty arthritis is acutely painful, quickly, usually red, hot, and the classic joint is the great toe. So having a suddenly painful, red, hot, sore, can't even let the bedclothes touch it, toe is often gout. So that's sort of classic. You can have gout in other joints as well, but it does tend to be a rather acute onset, a very hot and painful joint. And it's improved with icing it and the use of sometimes a very potent anti-inflammatory or prednisone to start with. But the ultimate treatment here is once you've had a gout attack, preventing future ones so that you don't destroy your joints.
Sure. Dr. Fernandez, a caller from Chisholm, age 17, was diagnosed with rheumatoid arthritis, now in his 40s. She saw her doctor and her rheumatoid factor was 10. What does that mean? And I'm going to add to this question. How do you know how do you follow people with rheumatoid arthritis as far as when do you decide to increase medications, decrease medications? Is it based on blood tests or what?
So a couple of things. Number one, young people can get arthritis, as this person is commenting. Number two, there is a blood marker. There's two. There's more coming down the line that allow us to look for antibodies in the blood of our patients to see whether they have rheumatoid arthritis or not. But remember, we treat the patient, and so there are some patients whose blood markers are normal, meaning negative. So I am assuming, based on our laboratory, that a rheumatoid factor of 10 is a negative marker in our laboratory test. But if a person has a red-hot swollen joint in a symmetric manner involving the small joints of the hands and feet, we can tell clinically that the person has rheumatoid arthritis. How do we treat our patients? We look at how they're feeling, whether they're having a lot of stiffness, whether there's a lot of swelling, whether they're having a lot of pain. And if there's a lot of inflammation, then there's a series of medications that we will start with one. And at this stage of the game, it is trial and error. In the future, we hope that we can tailor that to whatever is causing the inflammation in the patient. So that's how we would make the decision that the patient needs something more, that they need additional medications because their arthritis is not controlled.
Mm-hmm. Thank you. Dr. Khan, we have a caller from Thadic, Minnesota, wanting to know, she has trigger finger problems. Her fingers snap when in a painful position.
Yeah.
What can be done, what's happening, and what can be done about that?
Oh, again, a very common problem. What happens is that there are these tendons that attach your forearm muscles to your fingers, and when the muscles contract, they pull on the finger and causes the finger to bend. There's a little pulley mechanism here in the palm, and sometimes due to some scarring or some swelling, that pulley gets a little tight, and the tendon, instead of gliding freely, gets stuck, and you get a trigger finger. Usually cortisone injections locally are very effective in my experience. Occasionally, you know, if the problem keeps returning, surgery can fix it.
Mm-hmm. Thank you. Dr. Baldwin, here's a question. I was going to ask this myself. Can weather take a toll on arthritis, or is it a myth? Is arthritis worse when certain weather changes, or would people feel better if they all went to Arizona?
As long as there's no storms or changes in the pressure in Arizona. I don't know if there are any studies that have proven that. It's one of those things that you hear from so many people. It seems hard to not take a little bit seriously that some people have an effect when the weather changes.
What two of you think?
Well, I think there are rheumatologists in Arizona, California, Florida who are all doing well.
But I think some patients do notice that a change in the weather, not necessarily when we have the bad weather, but when there's a change in the barometric pressure, they may feel that they're a little bit more uncomfortable. So I think our patients, not everyone, some people will tell you that the weather does not make a difference, but I think the changes in the barometric pressure may trigger, for some patients, comfort level.
Thank you. Let's see. Dr. Fernandez, I guess I'll give you this question. Prednisone is commonly used for a lot of these inflammatory conditions. Prednisone is great, but it has potential problems too. So can you talk about the use of prednisone?
So prednisone is a very powerful anti-inflammatory drug, and is the only thing that our patients with inflammatory arthritis, by that I mean red, hot, swollen, very tender joints, it will work very quickly. So they will get relief very quickly. But prednisone, we have to respect it. If you take a lot of prednisone in high doses, you can have side effects, problems with infection, diabetes, broken bones, cataract formation. So there's a lot of concerns associated with high use of prednisone. Some of our patients do very well in very low doses, and now in the last decade or so, we use prednisone more what we call as a bridge to calm things down, get patients on good medications, and then get them off prednisone. Our goal is no longer, if we can avoid it, keep our patients on prednisone long term.
Sure. Dr. Khan, staying on the same subject,
Sure.
are there medications you can use instead of prednisone?
Yes, there are. I think you alluded to it earlier on. There are these immune modifiers or disease-modifying drugs. In some conditions, we can use them. In rheumatoid, actually, we use them as a matter of course as steroid-sparing drugs. But even in polymyalgia rheumatica, if we have a real difficulty weaning someone's prednisone, we might consider those drugs.
Dr. Baldwin, here's another question, north versus south, and maybe I can just throw this open to anyone. Is there more arthritis up here in the north where we're exposed to more elements, or is there any regional variations?
I mean, I can tell from my personal experience, having practiced here and in New England, psoriatic arthritis is much more common in our upper Midwest, and I've spoken to other rheumatologists in the Twin Cities, and that's their experience too.
So tell us about psoriatic arthritis. That's another one.
Yeah. Well, psoriasis is a skin condition, and about 1 in 3 people who have psoriasis can develop psoriatic arthritis, which can mimic or resemble rheumatoid arthritis, and the treatments are similar, but the psoriatic arthritis severity can vary from one person to another.
Thank you. Dr. Baldwin, a caller from Duluth, wants to know about costochondritis. What is that all about? And it flares up apparently at times. Is this a worrisome thing, or is it common?
Well, costochondritis, at least what I think of, is a condition where it's inflamed at the area where the cartilage and the bone are in close. So a lot of times in a person's chest wall, in their ribs, they'll feel this inflammation. So usually I treat it just like I would any other area of inflammation. Try gentle things first, heat, cold, and anti-inflammatory or Tylenol.
Thank you. Dr. Fernandez, a caller from Duluth, a good question here. Is it beneficial to keep moving to relieve symptoms of arthritis, or is rest better?
Generally, I do try to tell my patients, stay active. Now, you have a red hot, inflamed, swollen knee. No, you cannot go run the marathon. So there is a balance. If you're very swollen, very inflamed, it's more range of motion. It's more of a delicate type of exercise routine. But our patients who do stay active do much better.
Thank you. Dr. Khan, a caller from Hibbing, would like to know about the use of methotrexate in rheumatoid arthritis.
Yes, methotrexate is our mainstay drug in treating rheumatoid arthritis. It is a disease-modifying drug, meaning that it does control not only the arthritis, but prevents joint damage. And it was a revolutionary drug in the 80s, and we still use it. I would say the majority of our newly diagnosed patients go on methotrexate as a first-line drug.
First-line drug. Is that something, a disease-modifying drug
Yes,
that
absolutely.
actually will prevent joint destruction?
And slow down.
Yeah.
Great. Thank you. Dr. Baldwin, a caller from Duluth, has arthritis in her spine and neck, and sometimes it radiates to her hip. She's wondering, is 500 milligrams of aspirin a suitable treatment, or what other kind of medication could she take?
Well, 500 milligrams of aspirin, as long as she doesn't start to develop ears ringing or other symptoms of excessive aspirin use, it's a very good anti-inflammatory drug. Other things that are sometimes gentler, sometimes the other non-steroidals like ibuprofen or naproxen can be used to help relieve pain. And sometimes Tylenol, which is gentler to the stomach yet, won't relieve the inflammation, but will aid in, or at least to the way I was trained, it doesn't do much for inflammation, but it does change the pain and make it more tolerable.
Thank you. Dr. Fernandez, a caller, would like to know if rheumatoid arthritis can affect the lungs.
Yes, rheumatoid arthritis is what we call a systemic arthritis. Not only limited to the joints, we tend to recognize it because the joints are swollen, but our patients can have inflammation in the eye, they can have inflammation in the lining of the lungs, they can have inflammation of the skin. So it can affect the lungs, and in addition, some of the medications that we use to treat rheumatoid arthritis may have a rare side effect of affecting the lungs. So yes, we have what we call systemic features associated with rheumatoid arthritis.
Thank you. And finally, Dr. Khan, we just have a short time left. Are bone spurs caused by arthritis?
Generally, yes. Osteoarthritis, bone spurs and osteoarthritis go hand in hand in a lot of cases.
Thank you. Well, we're out of time. I'd like to thank our panelists, Dr. Gail Baldwin, Dr. Anna Fernandez, and Dr. Waseem Khan, and our medical students, Kate Aries, Ann Doring, and Tim Roos. Please join Dr. Ray Christensen next week for a program on orthopedic problems and joint replacement, when his panelists will be Dr. Bradley Edgerton, Dr. Patrick Hall, and Dr. Ken Ripp. Thank you for watching, and good night.